see this. So we're going to talk about the challenges surrounding impact and value evaluations of AI. Um, as Abdul mentioned, I work at the Healthcare Improvement Studies Institute of the University of Cambridge. I'm Dutch originally. I was trained in computer science in Utrecht. And then I worked in Amsterdam for more than 10 years at the University Hospital of the University of Amsterdam. That was a really useful experience to understand how such a complex healthcare organization works and how hard it can be, for instance, to change things and even harder to change things for the better. And if you very much focus on technology, like I am, or at least certainly was at the time, if you're in that environment, you start to appreciate that improving healthcare services and systems requires a lot more than just the technology. The technology can be key, but there's always a lot more that needs to happen in terms of people's behavior, the way they collaborate, the culture, and all those things. Then in 2014, I moved to the UK, to Manchester, where I became Professor of Health Informatics. And 2 years ago, I moved to Cambridge. I'm now a Professor of Data Science and Healthcare Improvement. And I think it's fair to say, over that period, I've moved away from being purely interested in technology into a much broader interest in how do we innovate healthcare services. In terms of the things I'm currently studying, researching, ambient voice technology, clinical prediction models, healthcare quality and safety broadly, and clinical decision support. And I've also here on the slide included some of my heroes, cultural heroes. So I'm a big fan of the music of David Bowie and James Brandon Lewis. He's a very good saxophone player. I like the films of Paul Thomas Anderson. The latest one is called One Battle After Another. That wasn't his best film, I must admit, but still very good. And I'm just about to finish Ian McEwan's last book, latest book, What We Can Know. It's very, very good, phenomenal, I would say. So I work at the Healthcare Improvement Studies Institute. We're not a technology-focused institute, although my work obviously is. But the institute broadly is a mixture of people coming from various different backgrounds. So we've got social scientists, behavioral scientists, we've got people with a healthcare, clinical background, we've got statisticians, data scientists, computer scientists like me, and we look at how we can develop a credible and strong actionable evidence base for healthcare improvement and innovation. And in creating that evidence base, we typically work collaboratively with different stakeholders in healthcare systems. So clinicians, patients, but also, for instance, payers. In the UK, those are commissioners, policymakers, healthcare organization administrators. So we try to be an honest broker in that very complex landscape that healthcare typically is, and work with all those different stakeholder groups to make healthcare better. And as I mentioned, in my work, that's typically focused on technology. In this lecture, we're going to look at AI as an intervention. So that means we're not going to talk about AI in terms of, deriving or developing models, data, machine learning. We're going to look at it really, once we have AI, a particular model, for instance, that has been developed, and we deploy it within healthcare, what is the impact of that? That's what we're going to talk about. So AI is an intervention. And we're going to focus on the use of AI within healthcare services. So we're not, for instance, going to talk about the use of AI by patients or consumers outside of healthcare services. And I'm not saying that that's not useful or interesting, it definitely is. But, well, we have to limit the scope of what we can do within an hour. So in this hour, we're going to focus on the use of AI within healthcare services, so being used by healthcare provider staff. We're going to talk about assistive AI, not autonomous AI. I've got a couple of slides about what that means, but basically it means that the AI is giving advice and not making any decisions for others. And the point that we're trying to achieve is demonstrating the impact and value of AI as an intervention in that context for patients, policymakers, and payers. So just 2 slides about assistive AI, and this is from a very old paper from Chuck Friedman, who's also one of my heroes, by the way. He works at the University of Michigan, and he came up with this equation, this formula that you see here. And if we think about assistive AI, what we're assuming, but also trying to demonstrate, is that a person who is equipped with or has access to the right technology, and that's the old computer that we see here, that icon, will perform better than a person that doesn't have access to that technology. That's fundamentally what we're trying to do. What that means is that we're not interested in the question whether computers are somehow smarter or better at performing certain tasks than people. That's something completely different. And that would be autonomous AI or AI agents. But here we're really talking about assistive AI. What's interesting is that the fact that we are pursuing this particular equation is that there are a number of things that follow. So first of all, it's more about people than technology, because we see 2 heads in the equation and only 1 computer. And in order for this hypothesis to hold, the system must offer something that the person doesn't already can or know. And that's really tricky because it's going to be different for every person, probably. And then finally, whether the hypothesis holds depends on an interaction between the person and the system, and the results of that interaction can never be fully predicted in advance. And that's a really fundamental thing. It's not to say that we can not predict at all what's going to happen, but we can't fully predict it. There's always some unpredicted, unanticipated consequences of that interaction. And that's really important for the field, for AI. Then what is value? What do we mean by value? I'd like to link this to what we call the quintuple aim. You might have heard of this. So the quintuple aim says that if we're trying to improve healthcare services, what we're really trying to do is improve patient experience, improve population health, so have better healthcare outcomes across the population, reduce the costs per capita, so do all those things with lower healthcare costs, improve the work life of healthcare staff, so support clinician well-being and reduce clinician burnout, and finally advance health equity, so address disparities and ensure fair access to healthcare. So these 5 broad goals are called the quintuple aim, and I think across the globe many people agree that this is really what we're trying to achieve when we're trying to improve healthcare systems and services. So I think it's basically not controversial. But I think it's important to keep these aims in mind whenever we say that we want to demonstrate that AI has a value for healthcare. Then that means that, you know, we're basically trying to address the things, these 5 things here, or at least some of them. And then finally, if we evaluate impact, then we're talking about a causal effect, right? So we were talking about AI as an intervention and evaluating the impact of AI as an intervention. It means that we're looking at the causal effect of what the AI is doing to behavior, probably, and decision making, and ultimately to patient outcomes. And that means that ideally we will have to do a trial, a randomized trial, like we see here. So we've got a group of patients. It's chance that determines whether they will end up in the treatment group or the control group. If they are in the treatment group, they will receive an intervention. If they are in a control group, they will not receive the intervention. We do see some pills here, so they will receive a placebo intervention if it is a drug trial, and that's what we're looking at here in the diagram. And then finally, we will compare the outcomes of the intervention, the treatment group, and the control group. And if statistically the outcomes in the treatment group are better than in the control group, then we will say this treatment has an impact, a positive impact on outcomes. So I'm just going to stop here for a second. Let me stop sharing. And I've got a question for you, which is, why do we need to randomize? Can we not just compare people who received a certain treatment with those who didn't receive the treatment? And wouldn't that just give us the answer that we're after? Why is it so important that we randomize? Does anyone know that? If you know the answer, please raise your hand, and then you will get the opportunity to unmute. I can see there's two people with their hand raised. So David, please go ahead.
Randomization is used so that bias can be counteracted.
And what would that bias be? In what sense could there be bias?
If you know whether you're receiving the treatment, if you know if you're in the intervention group as opposed to the placebo group, then you may have preconceived notions as to, wow, this is going to be better. So you think that there's a benefit that may not actually exist. Similarly, if you have biases against certain things, in many cases, I don't really trust this treatment. I don't really like this drug. I don't like these side effects, which may or may not be real. It may just be in your imagination. But again, you may give a result that's not a true indication. Those are just two of the ways that bias can interact with it. There's selection bias, misclassification bias. There are different kinds of biases.
Yeah, I think what you're saying, and I agree, although I think what you're referring to is blinding. So in a drug trial, patients typically do not know whether they are in the treatment group or the control group. And that's what we call blinding. So they are unaware whether they are receiving the treatment or not. So that means that, as you say, if they have a preconceived idea about the treatment, whether it works or not, that is not going to influence their response because they don't know. But that's not the same as randomization. So randomization means that it is chance that determines in which group you are. I see that Shabana has her hand up, or had her hand up. Did you want to come in, Shabana?
Oh, can you hear me now?
Yes.
Oh, okay. So, I was going in the same direction as what David explained. It's really the gold standard. However, in this case, there's a possibility the randomization can uh, basically it's randomization, not in terms of drugs where the patients are unaware whether they are receiving the treatment or they are in the placebo group. In this case, people who are using AI to support patient care, randomization would help them. How should I explain? Randomization would help them to understand whether the treatment plan is working for the benefit of the patient. I don't know if I am making it clear or not.
Yeah, thanks, Shabana. I think that was helpful. Let me go back to the slides, and so I'm going to share again.
I just hand anyway, if you want to.
Can you see my screen again? I think you can, right?
Yes, we can.
Thanks. So the reason that we have to randomize, suppose that we wouldn't randomize. So we would just have a group of people who receive the treatment and a group of people who do not receive the treatment. There would probably be some reason why the people who are receiving the treatment are receiving the treatment. So probably they are more ill, or there's another reason that they are receiving the treatment. And therefore, the two groups can't be compared. If we would compare them and compare their outcomes, we would get a biased result because there would be two things that are different between the two groups. So one group receives treatment, but also to start with, they were different than the control group. And the only way to really be 100% sure that there is no difference between the treatment and control group, not something that we know, also not something that we do not know, we have to randomize. So that's the reason that randomized controlled clinical trials are the gold standard to evaluate drugs, but also other interventions in healthcare. So we're going to look at a bit of history, and we're going to go back to the 1970s. But first, I've got this slide to look at the history of AI in healthcare. So if we think about how the field has developed, the foundations, I think, were laid in the 1940s to 60s. In the 1970s, we had the first systems. And then in the 1980s and 90s, the first clinical studies. I think the person who run the Acorn trials on the call. And then in the 2000s, we had many decision support technologies entering healthcare, including routine healthcare services, and many clinical studies evaluating these decision support tools. The breakthroughs in AI as we know it now came in the 2010s, especially in image-based diagnosis and other image-based tasks. And then in the current decade, we have a number of very rapid developments of AI in healthcare, including generative AI. So we're going to go back to the 1970s, where in the city of Leeds in England, a system was developed called AAP Help, and that was for decision support in acute abdominal pain. And you are probably aware that acute abdominal pain can be a sign of appendicitis, and appendicitis is something that you really have to treat. If you do not treat it, it can cause many life-threatening complications in the abdomen. So if a patient presents with acute abdominal pain at the emergency services, then really what you have to figure out is, does this patient have appendicitis or not? If they haven't got that, there could be other quite serious conditions, by the way, but it also may be the case that nothing really serious is going on. And in that case, you do not want to remove the appendix because that's the treatment for appendicitis. But if you haven't got that, we really shouldn't remove the appendix. So this system provides diagnostic decision support. We're looking here, by the way, at a version that's not from the 1970s, but a little bit later, but basically internally it was still the same system. And we see here one of the screens that clinicians use when they enter data into the system. And in this case, here they indicate where the pain is located, or at least where it was located at onset and where it is currently located, and what the aggregating factors are for the pain. In this case, it's movement, coughing, respiration, what relieving factors are, and for instance, whether things have gotten better or worse over time, how long the patient has been experiencing this pain, things like that. So you can imagine that all of this is very important for the diagnosis. There's a couple of other tabs that need to be completed. So this is not the only type of information, but by the end of, after entering all that information, the system comes up with a differential diagnosis. And it actually comes up with two differential diagnoses. One is based on a database of emergency department patients, A&E database. And another one is based on patients in the wards. And obviously, that setting determines a lot in terms of your risk of having various conditions. So therefore, the system provides these two differentials. If we look at the left-hand side, the differential diagnosis on the left-hand side, we see that the system believes that there's a 69% chance of NSAP, stands for non-specific abdominal pain. Basically means we haven't got a clue what's going on, but it's probably not really dangerous or something that we need to treat. It will just pass. There's a 12.2% that the patient has appendicitis, Whether that percentage is high enough to operate, I don't know, perhaps. I mean, that's a trade-off of different risk, etc. And then there are other conditions listed, dyspepsia, renal colic, etc., etc. Most of them very, very small percentages, so very, very unlikely. So this was the system, AAP Help, and the system was evaluated in a randomized trial. So the kind of study that we were just looking at for drugs, but now it was with this system, so not a drug. And this happened in 4 hospitals in England, and a total of 16,000 patients were included in the study. And 112 doctors were randomized to either use AAP Help or not use it and provide the care as they were used to providing care and make diagnosis. And the primary outcome measure was initial diagnostic accuracy. So the diagnostic accuracy of the first doctor to see the case. So I've got a question again. Why did they randomize the doctors and not the patients? That's quite odd, isn't it? Previously we were talking, so I'm going to stop sharing again. We were talking about these drug trials, and in these drug trials we randomize patients. But here, the doctors were randomized. Does anyone know why that is? Or have a guess why they did that?
Because the doctors are the end users of the AAP help system as compared to the patient. So I think they would rather the people who are directly using the system to be tested, to be controlled and randomized.
Yeah, so suppose that we would randomize the patients rather than the doctors. What would go wrong, you think?
Hey everyone. So in terms of what would go wrong, because the intervention is actually the system, right? So we need to target trialing the intervention. So if we randomize the patients, the intervention is like too far up the chain, so to speak. And we wouldn't get the appropriate outcome that we were hoping for because we didn't randomize the clinicians. So we would still be opening up those potential for biases, blinding, things like that. We wouldn't actually mitigate, and it wouldn't be randomized.
Yeah, thanks, Victoria. So what would happen is that, suppose I'm a doctor and I'm taking part in this trial, but the patients are randomized. What that would mean is that I would see a patient, I would be able to use the system because this patient would be in the treatment group. And I would use the system and base my diagnosis on that. And then I would see another patient later in the day, perhaps, but this patient would be in the control group. So this time I would not be able to use the system. But perhaps this patient is very similar as to the one that I just saw this morning. So I still remember what the system told me. So we've now got this strange situation that even though I'm treating a control patient, I'm still kind of using the system because I remember what it told me earlier. And this is what we call contamination. And indeed, because the system is the intervention and the clinicians are the users of the system, you could very easily get very, very strong contamination or learning effects if you do it like that. And we wouldn't be able to trust the results of that kind of trial. So really what we have to do is randomize the doctors. Sometimes we even randomize entire units or hospitals, depending on what is feasible, because randomization of doctors is not so easy logistically. So the primary outcome, as I mentioned, was initial diagnostic accuracy. And what they found in this trial of AAP Help is that accuracy, diagnostic accuracy, rose from 45%, 45.7% to 64.8%. So that's a massive increase. And there were very good downstream effects as well. So the number of people who received surgery, but then where it was found that they actually didn't have appendicitis, that's called a negative appendectomy, that rate dropped by almost 50%. but also the number of people who had the most serious complication of appendicitis, which is called a perforation, that number dropped as well. So good outcomes all around. Now, in the study, in this trial, they didn't use this system that I showed you. They used a form, the form that you see here. But on that form, we got the same information as this system, basically, because this was at a time where people didn't have computers on their desktops or in their pockets. So what happened in the trial is that the doctor would complete this form, and then it would be given to an engineer, and the engineer would enter all the data into a computer that was located in a different room. The computer would then print the outputs, and that was taken back to the clinician. That's how it works. So it just feels quite complicated, very different than how things are nowadays. So what they also tested is what happened if people just used the forms. So no computer, no advice, no IAP help, but completing the form whilst you are doing the diagnosis. If clinicians did that, the diagnostic accuracy improved also quite considerably, not as high as with the advice, but still about 10%. So I'm going to stop sharing again because I've got a question for you guys. Why is that? Why is just completing a form helping people to make better diagnoses? David.
It standardized the organization of thought in a way that aligns with part of the algorithm the computer would have been using, as opposed to everybody approaching this with their own ideas and whether or not they followed a script or deviated from a script from day to day, hour to hour.
Yeah, that's spot on. I think it really illustrates the point that people are terrible in organizing their thoughts. And if you want to do this properly, this type of task, a diagnosis, you really have to be very, very systematic. And as you said, David, the form forces you to do that, to be very systematic, something that people are not good at. So the form itself is actually a very good intervention to become a better diagnostician. And I think what's really interesting about this is that we see here that something that is quite superficial, on the outside here, so the form is itself an intervention. And I think this is what we see very often with, well, digital interventions and certainly with AI, that actually they are multifaceted. There's not one thing, there's a number of things going on. And if we want to really figure out what the impact is, we have to try to split out these different things, which they did in a very smart way in this trial with AAP help. But it does make things much more complicated because a simple trial with treatment versus control is not going to do the job. So in this AAP help trial, they actually had 3 arms and they randomized the doctors between 3 arms. So it was nothing, just forms or forms and advice. So this complicates things. Let me go back to the presentation. And we're going to move on to the next section of today's lecture. Why do we need clinical studies? And I'm going to use something from one of my other heroes, actually, from the field, Enrico Corriera. He works in Sydney at the University of Macquarie. And he's come up with this diagram called the information value chain, which says that in order to have an impact from any information resource, be it, some information system or something very advanced like AI, there first needs to be an interaction between the user and that system. Then the user has to receive the relevant information. That then will have to lead to them making a different decision than they would have made without that information. That needs to then be actioned by having a change in care processes. And then finally, that can lead to a different outcome for the patient that they are treating. There's a lot of steps here, right? And if anything breaks down along this chain, we will not have a change in outcome. So you can see that it's quite brittle. If we think about the AAP help system, this is how it works. So we've got the clinician who completes the form, that's the interaction. Then the system provides the diagnostic advice. Then the decision that we're looking at is the initial diagnosis. And that needs to be different than without the form and the advice, otherwise nothing has changed. And that then needs to materialize into a surgery or no surgery decision, and that will have an effect on outcomes like negative appendectomy and perforation. So that's how it works for AAP help. I'm going to use another example to illustrate this information value chain. And these are medication alerts, and you're probably familiar with them. So we've got an example here. It's quite old, actually, as you can see, but the point is that here's a clinician who's trying to order medication, and the medication that they're trying to order is called Captopril. That's just below the orange bar. You are ordering Captopril. And then this pop-up screen has emerged, which warns for a potential allergy. It says the patient has a probable allergy ACE inhibitor because Captopril is an ACE inhibitor, and the possible reaction is anaphylaxis, and that's pretty serious. And now the clinician has to respond by either cancelling the medication order or proceeding, but then the clinician has to give a reason to override this alert. So going back to the information value chain, how does this work for medication alerts? So the interaction is the clinician initiates the medication prescription, then the decision support system issues the alert, and then that leads to either the original prescription being cancelled and an alternative treatment being prescribed instead. That alternative treatment is then administered to the patient. That's the change in care process. And finally, that leads to hopefully the avoidance of an adverse drug event, anaphylaxis in this particular example. So that's a change in outcome. So again, you can see that we have to go through all these steps to achieve what we ultimately want to achieve, which is the change outcome. Now, one issue with these systems, and you're probably familiar with this as well, is alert fatigue. So we know from numerous studies, and this is quite an old one, that drug safety alerts are overridden in the majority of cases. And the reason is that many systems issue so many alerts that a phenomenon called alert fatigue kicks in, and basically clinicians don't have the possibility to look at all these different alerts, and they just override them all, they just ignore them all. One of the reasons that this happens, apart from the enormous number of alerts, has also to do with workflow issues. And this is a really nice study from the University of Edinburgh. It was published about 10, 12 years ago now. And what they did is they looked at GP consultations, primary care consultations. So they analyzed more than 100 consultations in 8 GPs in 3 practices. And they looked at the flow of events, typically when medication was being prescribed. And what they found is that if that happened, the GP had typically already formulated the problem, spent some time probably to consider, explain, and negotiate and reach an agreement with the patient about the proposed treatment. Had maybe given instructions about that treatment and printed a leaflet. And only then they would enter that order into their system, leading to an alert. And by that time, the consultation was basically over, right? Because they've done all that work, all that explaining, negotiating. So if by that time you receive an alert, it's very, very unlikely that you still go back. And that's exactly also what they found. So there were a total of 132 prescriptions in those 112 consultations, and 81 attracted at least one alert, but only 3 resulted in the GP checking, but not changing the prescription. So here's a clear workflow issue that those alerts appear much too late to be realistically actioned upon by GPs. And obviously, if that happens, if we have these workflow issues or usability issues, that means that the chain will break down and we're not going to have a change in decision and therefore not a change in care process and not a change in outcome. Many people have pointed out this issue, and therefore there's a lot of recommendations that whenever we evaluate AI in healthcare, we have to start with technical performance. So we have to check whether the system actually works and whether, for instance, alerts that it issues or predictions that it gives are accurate. But then we have to check whether the way we are providing that information to clinicians fits into their clinical workflow and whether there are no usability issues in the interaction with the system. And only once we've done that, we can proceed with assessing the impact on the things that really matter. So this is from a recent paper from Jackson and Shortliff, and the framework is from the American Medical Informatics Association. So let's go to the next topic, which is something called the AI chasm. And that's another challenge if we want to demonstrate the impact and value of AI. So the number of AI that is being developed for healthcare, the number of systems and models that are being developed is growing very, very fast. So here's one example, prediction models. That's only one type of AI. There was a study published just a couple of months ago from a Dutch group from Maastricht. They did a bibliometric analysis of all the studies reporting the development of a prediction model since 1950. Now you can see here from the graph that for a very long time there were very few studies that did that, but things started to change around 2010, 2015. And in recent years, the number of models, AI clinical prediction models that have been published is growing very, very fast. So at the moment, we're looking at about 250,000, 270,000 models that have been published, and that number increases with about 10,000 every year. The problem is that most of these models never make it into clinical practice. So here's a review from obstetrics, and it was published in 2016. And the authors looked at prediction models that had been developed for the field of obstetrics. So looking at things like preeclampsia, preterm delivery, gestational hypertension. They found hundreds of models, but for none of these models, the impact on clinical practice had been evaluated. So we don't know whether they actually make a difference on clinical decision-making or outcomes. And for that reason, none of these models are being recommended by clinical guidelines. So the impact that all of this is making on healthcare is really very modest, if not completely absent. We also see this in other statistics. So this is something called the Global Clinical Artificial Intelligence Dashboard. You can look it up yourself. It's freely available on the web, and it scrapes the web for clinical or healthcare related AI studies, papers. And this is from last month, I think. Yes, I created the screenshot in September. And it makes a distinction between the total number of published studies and the number of mature studies. So studies that involve some form of clinical or real world evaluation. And you can see from the graph that number, it is growing, but it's growing only very, very slowly. Whereas the number of AI model development studies, the blue line, is going up very, very quickly. So this is what we call the AI chasm, I should say. And I think the result of that, the upshot of that, is that we are still in the foothills of clinical AI research. Here's a review that was published last year in Lancet Digital Health. where they looked at randomized controlled clinical trials on AI in clinical practice specifically. They found 86 of those trials, and those were mostly deep learning systems for medical imaging and particular gastroenterology and radiology. And the majority of those trials report positive primary endpoints, but most of these trials were single center, which is considered a relatively weak evaluation because we don't know whether the results are going to generalize to other centers. And also the authors noticed that the reporting quality of these trials, these AI trials, is pretty poor. Certainly if you compare them, for instance, with drug trials. So really, when it comes to the evaluation of clinical AI, healthcare AI, we're only just beginning, I would say. And then there's another problem, which is called the RCT AI timeline mismatch. So if you want to conduct a randomized controlled clinical trial, you're probably looking at 4 to 5 years, if not more. My experience is it actually takes even more than that, from the initial idea and conception of such a trial to completing the trial and publishing the results, because there's many steps that you have to go through. So you have to find money, funding to do the study. You have to develop a protocol. That protocol will have to be reviewed by a review board or ethical committee. Once you're ready to go, you will have to recruit your clinicians and patients for the study. You'll have to do your data collection, perhaps with a certain follow-up time. And once that's all done, you can analyze the data and publish the results. 4 to 5 years at the very least, I would say. If we look at what has happened in the last 5 years in the field of AI, that's enormous. So in 2021, which is 4 years ago now, we didn't have ChatGPT, but we did have AlphaFold. That was the big news at that time. Seems quite a long time ago now. In 2022, 3 years ago, ChatGPT appeared on the market. In 2023, we had foundation models, which was the big story. 2024, ambient voice technology, and at the moment, agentic AI, I think, is what most people are very excited about. So these are enormous developments, and for a trial, we will have to always freeze the technology for the duration of the study. So suppose we want to do a trial with ambient voice technology, which I think is really important and needs to happen. We would then have the results probably by 2028 or so at the earliest. But by that time, there's going to be a lot of new things that will have been developed and a lot of new AI technology, and we will not be able to take advantage of that new technology in the trial. And by the time we publish, people will say, well, this is now outdated. So the final topic I want to discuss with you is transportability of AI models. And I'm going to use an example from EPIC, the EPIC sepsis model, and some of you might have heard about this. So the EPIC sepsis model, ESM, is an alert system that identifies hospitalized patients at risk of developing sepsis. And there's a prediction model that underlies the system, and that was developed on data from, I think, collected at 3 healthcare systems in the US in 2013 to 2015, about 400,000 patients. And EPIC say they never published the details of the development or the model, but they claim that they found in an internal validation that the model had an AUC of 0.76 to 0.83. And then a couple of years later, in 2018 and 2019, a group from Michigan validated the model in their own hospital. And they found an AUC of 0.63, which is dramatically lower than what EPIC claims that the AUC of the model was. And the numbers that came with this validation were quite devastating. So for instance, in Michigan, they found that the model only identified 7% of patients with sepsis who were missed by a clinician. Conversely, it didn't identify 67%, 2/3 of the patients with sepsis, despite the fact that it generated almost 7,000 alerts. The question is, why is this happening, and why is what they found so different than what Epic claims to have found when they developed and validated their model? It's not an entirely unique finding. I think that's important to realize. So here's a study of a prediction model looking to predict obstructive coronary artery disease in patients with chest pain. It was an academic, so not a commercial model, developed on data from more than 5,000 patients from European and US centers. And then when it was validated on data from Innsbruck, Austria, and that hospital was not part of the development, the model was completely off. And it was very, very poorly calibrated, and basically came up with predictions that were way too high. So why do prediction models fail to transport between sites? I think this is a problem that is not entirely understood yet, but I think we do know some of the reasons. So one reason is that sometimes models are developed with insufficient sample size, which means that they're overfitting the training data, and then they will not generalize to other data sets and other sites. But there's more reasons than just that, because I think that the majority of models that are nowadays published are not necessarily overfitting the data, and you would have sufficient sample sizes. Other reasons are that there are going to be differences in patient case mix between different hospitals, different settings. There's also going to be differences in how data are being collected and how things, for instance, are being measured. And because the AI models depend so much on data and are so much fitted towards the training data, if there are these differences in data collection and measurement, you're going to see that immediately in terms of the outputs, and the outputs are going to be worse. And then the final reason is that there's always a form of data drift over time. So populations change, healthcare procedures change, the way that healthcare organizations function change over time. These are all typically quite small changes, but still, if we're looking at a number of years, then they add up, and we may find that a model that was developed, for instance, 5 to 10 years ago is no longer working well today. So let me wrap up before we go to Q&A. A couple of key points. It's important to realize that we can have a very accurate algorithm, but that doesn't mean that that algorithm is going to have value and impact. And the reason is that there are these usability and workflow barriers in between. So think about Enrico Guerrero's information value chain. We have to go through the chain always, otherwise it's not going to work. So we may have things on the left-hand side of the chain that are very, very good, but end up with nothing at the far end of the chain. The second key point, the AI chasm. There are far fewer clinical evaluations than AI models being developed. It's not something that we can easily change, but it does mean that we are in this strange situation that there's so much technology and so many models, but we don't know very much about what their impact is, what their value is for healthcare services. And then finally, there are a number of really critical evaluation challenges which make it much harder to evaluate AI than to evaluate a drug. So one thing, there are no placebos. And I forgot to mention it on the slide, but we can't blind people, as we were saying earlier, right? So in a drug trial, we can blind people so they don't know whether they are being treated or not. In an AI trial, that's not possible. We have to randomize at clinician or facility level. We can't randomize patients. AI interventions are very often multifaceted, as we saw with AAP Help. The technology becomes outdated while we are doing our study. And finally, there's often a very poor cross-site transportability. So the models do not apply universally across different systems and settings. So thank you very much for listening.